Hello and welcome to a new episode of Home of Medicine podcast in association with the Royal College of Physicians, Edinburgh. My name is Ben Lovell and I'm a consultant in acute medicine working in London, and I'm joined by my co-host.
Hi, I'm Dr. Amie Burbridge, also a consultant in acute and general medicine and Director of Professional Development at Lincoln Medical School.
Lest we forget, and we're very, very proud of you. So I've got a case for you this week, Amie, and it's a bit different to usual because we normally do new cases that present to us via the take or via same-day emergency care. But of course, another big part of the acute medic's job is the acute medicine unit, the ward. And this is a patient who I, inverted commas, inherited when I began my AMU week. Had already been on the ward for a day or so, but had been admitted, been clerked, then post-taken by a colleague, was admitted to the AMU. And then I come on a Monday morning and I do my ward round and I meet him for the first time. And it's a 49-year-old chap. And this man, I think, was on day 2 of his admission now. And he was admitted with a flare of his severe chronic back pain. So bad that he was unable to mobilize at home because the pain was so bad. And this is a gentleman who had unfortunately lived with back pain for a very long time. He was well known to our complex pain clinic here. And he'd had multiple previous MRIs of his spine. The most recent was just 2 months ago, and it confirmed he had multi-disc degeneration with multiple site radiculopathies in the lumbar spine, with compressed discs that were irritating L3 and L4 bilaterally, which was the cause of all of his pain. And he was unknown as yet to the neurosurgeons, and the plan was to marry this conservatively, but he lived with back pain and he did get flares. He'd previously tried nerve root injections via the pain team as an outpatient, but unfortunately he'd never had any decent response to this. And he'd also was taking quite a lot of medications for this. He was on gabapentin, 900 milligrams 3 times a day, and amitriptyline, 50 milligrams at night. So big doses of neuropathic pain meds. But this pain flare, like his previous pain flares, was so severe, he had taken to his bed at home and couldn't even get out of bed to walk to the loo. So he was seen in the emergency department, referred to the medics on the basis of poorly controlled pain, or suboptimally, let's say. And despite the best efforts of the clerking team to turn him around and get him home again, he was admitted as unable to carry out any tasks, activities of daily living at home, and was admitted to the acute medicine unit, where he had taken to his bed and then the next morning met yours truly. So is this the sort of case you're familiar with as a consultant in acute medicine? You met patients like this before? And if so, what's your thought process here and what's your usual strategy?
Absolutely. I have seen patients with very similar presenting complaints with chronic, whether it be chronic back pain, it could be chronic pain that's not managed adequately. And I always like to think that if somebody's in pain, we're not doing our job, because nobody should be in pain. There should be enough pain control and options available out there for people to be able to be pain-free. But I know that in reality, that's not exactly correct. My job as an acute physician is to make sure that this gentleman does not have an acute cause of the back pain. What I don't want to do is to assume that this is a flare of chronic back pain. Just because he's known to have all of these complicated spinal problems, radiculopathy, multidisc degeneration, it doesn't mean that this isn't something completely new. So I want to go back to the beginning. I want to take a history. Is it the same? Is it any different? Any bowel or bladder involvement? Could this be called equina? Is this definitely something that is happening in the spine, or is it something that is muscular? Could it be sacral region? Is this an infection? Is this a fracture? Anybody who's got this level of degeneration is probably going to have some osteopenia. Could he have an osteoporotic fracture? 49-year-old man, it's unusual, but think about it. Think about any trauma that he could have had. Has he been taking the medication? Has he been able to absorb the medication, or has he had any recent illness that has meant he hasn't taken it or not absorbing it? Any diarrhea and vomiting, for example. I also want to know, does he have any other signs and symptoms apart from the back pain? Fever, weight loss, appetite, breathing problems, any changes in bowel habit, any chest pain, any shortness of breath? So really, I don't want to assume that this is all due to the chronic back pain because, well, that's easy, isn't it? It's easy for us to do that.
What's wrong with easy?
Nothing is wrong with easy. And that's what I need to stop. I make my life really hard in all areas of my life, not just medicine. And you know what? Sometimes maybe I should just go, this is chronic back pain, pain relief, observe home. But I'm like, no, there must be something else going on here. I must spend 2 hours figuring out what's going on. It's my mind. It's the way it works. I've tried to change. I can't change, Ben.
I think there's some really good stuff in what you say. And I think you're right in that when someone comes in with a condition they presented with many times before, we have to check it fits the pattern. Because of course they can come up with something new.
Absolutely.
So I think checking that it fits the pattern, and the way I check it fits the pattern is by asking the patient.
Yeah.
And you know, whether it's someone who's coming with a flare of chronic, I tell you what, I see a lot of people who come in with a flare of cyclical vomiting syndrome, so severe abdominal pain and can't keep anything down. And I see that quite a lot. So most of those people do in fact have a flare up of this condition which waxes and wanes, but every now and again someone will have something else. They'll have a gastroenteritis or something, or more sinister pathology there. So my process is to say, does this feel like your usual flare of X? And let the patient tell me. Your other question about, was he taking his medications, or if so, was he keeping them down? Was he vomiting or anything? He was taking those meds and he wanted more. The handover I got was that he is asking for morphine and Oromorph and morphine preparations because his pain's very, very bad. So we can talk maybe a little bit about how to manage flare of chronic pains and the do's and the don'ts. In fact, let's talk about it now. So one of the things I hate to do with people who truly have a flare of a chronic pain syndrome, because it does them so much harm, is admit them to an inpatient bed, because it is very difficult to suppress a flare when you do what all patients do in hospital, which is lie completely flat for 23 hours a day. Once you stop walking around and getting up and going to the loo, everything sort of freezes in position. I see it's a lot with back pain as well. So my first goal, once I've satisfied myself that this is a pattern, this is a flare of a chronic pain syndrome, is to do everything I can to try and avoid them coming into hospital. But that's not always possible. The other thing I do is think about pain medications. We have really good links with our pain team in my hospital, the complex pain team. And people who do have chronic pain disorders sometimes have a pain plan in their notes somewhere, saying when they do present acutely via ED with a flare up of chronic pain, here's a few things that you should try and things that maybe you shouldn't try. And the one thing, and they're really, really helpful. And one thing they often say, the chronic pain team, is do try to avoid starting them on opiates, particularly long-acting opiates. And that's not out of any sense of denying patient a comfort or pain relief who are suffering. It's about trying to balance short-term versus long-term problems. And they have enough evidence to know that when you start opiate preparation, particularly long-acting and modified release ones, it actually sends them down on a downward trajectory over time, months and years. Very difficult to get them stopped again. It affects their pain threshold, which means that the further flare-ups of pain need bigger and bigger doses. We did go through a period maybe 10, 15 years ago where I'd meet people who were taking MST, morphine sulfate tablets, on something like 150 milligrams twice a day just to feel normal, because those medications had been started by well-meaning people trying to get them more comfortable. So I would check the pain, their notes, see if they were known to the pain team, did they have a good pain plan for how to get on top of a flare like this? But going back to this particular case, I went to meet the patient and I said to him, does this feel like your normal pain flare up? This is your pain times 100. Is that right? And he said, absolutely, yes, but this is the worst it's been. But it's the same place and it's killing me. I want an MRI and I need some morphine. very clear with what he wanted. And he'd been seen by our therapists to see what he was like on his feet. And they said, we couldn't even get him out of bed. He was in so much pain. He's refusing to walk. Maybe we'll come back later after he's had a good dose of some, maybe some Oromorph or something. We'll try him again and see what he can and can't do. But he is usually independent at home, and he's a long, long way from that particular baseline. So let's pause there for a second.
Mm-hmm.
Any thoughts?
Oh, many. What I think we have to be very careful not to do is to underestimate people's pain and to say to people, you can't be in that much pain. It can't be that painful. Because who are we to question that? Pain is a very subjective sensation, not an objective sensation. It's subjective. But on the opposite side of things as well, I guess the question I want to ask is, what do you want me to do? He wants an MRI, he wants some pain relief. I'm going to do that because he's in pain and he's telling me he's in pain and he's asking for an MRI. His last one was 2 months ago. It's worse than ever. How do I know something acute hasn't happened? I guess in the back of my mind is this medication-seeking behaviour? But I can't say that after meeting this individual once. And I don't want to stereotype and I don't want to pass that judgment. So it's really difficult. I find these cases incredibly challenging.
Yeah, they are.
Really, really difficult. And I don't think there is a right way of doing things. I think there are very wrong ways of doing things, but not necessarily. I think we can all manage it in a slightly different way, but it will be the right way, if that makes sense.
I've been on the other side. I've been a patient and had horrendous pain. I had to have an operation. And after the operation, the pain was more than I envisaged it could be. And I remember being quite struck by, I wanted to ask for pain control, but it does sound so funny when you ask for strong painkillers. It sounds funny. It sounds like you're drug seeking. And I was drug seeking because I was in agony. So I was seeking a drug. So, but and even in my own ears saying, look, you're giving me dihydrocodeine. I'm in severe pain. I'm in 8 out of 10 pain. I need something stronger. And, maybe it was all in my head, but were they looking at me funny? Were they writing something in my notes? And I was struck by being told by medical and nursing staff a couple of interesting sentences. One was, but people aren't usually in this much pain after this procedure, was one. I don't know what I'm supposed to do with that information. And the other one was, but most people aren't in this much pain after they've had this much painkiller. Again, well, I must be your outlier. Maybe I'm a wimp. I'm so sorry, but I'm not asking for a script to take home with me. I'm asking, could you get me through the next 12 hours, through the night, with the state, curled up in the fetal position, shaking in agony. But I was denied that pain. So it sort of changed me a little bit about how I approach pain and patients. This is quite a few years ago. It happened to me. And if a patient says, I'm in agonizing pain, I have absolutely no way of disproving this.
Of course.
And why should I try and disprove it anyway? But you're right. There are a few wrong things to do, and I wanted to get it right. And I think the wrong things to do would be, I feel like the wrong thing to do would be just, okay, let's just keep giving you injections of morphine to you till you're not in pain anymore, because that carries risk, short-term risk. I don't want people coming back to me and saying, hey, that guy you gave 10 milligrams of IV morphine to, well, he won't wake up and his pupils are pinpointed and his respiratory rate's 4. And also, I don't want him to be in a position saying, I only feel good now I've had the morphine. I need it. How do I wean that? It's easier if someone's got an acute injury, a trauma, a broken bone, a surgery, and thinking, okay, a bit of strong morphine for the next few days, it sounds reasonable to me until the body starts to heal. But a flare of a chronic condition, then I do worry about introducing a potent opiate to the mix, because I don't know if that helps in getting them back into remission again. And I don't know what happens the next time they get a flare up. If anything will suffice except the morphine, except maybe next time it's got to be 15 milligrams. So I'm worried about future him as well as current him. I also think the wrong thing to do, and I've seen this approach before, is saying, well, I can't give you any of the stronger painkiller because I'm looking at your pain plan here from the pain clinic, the pain team, and they're saying that we're not allowed to give you morphine. So what can I do? Yeah, that sort of splitting of teams and making one team a bad guy and I'm the good guy doesn't help anybody down the line with that patient's relationships with the hospital. So I said to the patient as well, and another question I ask patients with flares of chronic pain is, how long does it normally take you to turn the corner when your condition flares up like this? How many days? And if they say it's usually minimum 3 days in hospital and then another week after that, that helps me sort of measure a bit and saying, okay, well, we're on day 2 now. I'm really hopeful you're going to start to turn the corner in the next 24 hours. Let's just see what we can do to make it a bit more comfortable today and give it a bit of time. I won't push the physio today if you simply are not up to it, but we got to try tomorrow morning, haven't we? Because I don't want you to, be stuck in your bed and then get all sorts of problems with back pains, the circulation and blood clots and all that sort of thing. So why don't we make a deal to leave you be today, see what you can get some rest and get some food into you. And then tomorrow we'll meet again and see if you're in a better place to get up and start moving around very, very gently, and see if that brings any sort of relief or comfort. And sometimes you can fashion out a plan like that. And I said to him, I don't think we need to do the MRI because you've had a lot of MRIs in the past. The most recent was 2 months ago, and it gave us the answer. We do MRIs to get an answer. MRIs are not a therapeutic intervention. Although I wonder if some people feel a bit better after they had one because it takes away anxiety. But I don't need to do an MRI to make you feel better. I do an MRI if I want to ask a question. Why are you in such terrific back pain? But I actually know the answer, don't I? The MRI 2 months ago showed me, I know why you're in terrific back pain. You've got all these horrible bulging discs and these compression radiculopathies, and you've got nerve roots being touched and irritated by discs, and that and it flares up and it settles down. It flares up and it settles down. I've got the clinical answer I need. So that's why I don't think we need to push for an MRI today. And I hope you think I'm being reasonable with that. I say to the patient. And yeah, so that was my sort of approach on the ward round. A bit longer than it normally takes me, but these aren't the cases which it's a quick in and out.
How do you know that there wasn't anything new going on?
I guess I use my clinical deduction. I ask the patient, maybe, when I'm saying, does this feel like your usual flare up, which happens every few months, or does it feel like something new is going on? That can be quite telling. If they say, I've never had this numbness going down one leg before. Well, okay. All right. That's new. I've never lost control of my bladder before. I've never had these fevers before. I've never vomited before. Those sorts of things would say, okay, this sounds new.
So it's red flags.
Yeah. If it's ticking all the boxes for their usual flare up, maybe I've met them before on their previous admissions. I've been in the same hospital for yonks now. I know some of these patients. So I use a bit of judgment. Of course, I should always examine my patient and look at their vital signs. And I did look at this chap's vital signs. They were all within range. They were all normal. Okay. I examined his legs. I always examine the legs and people with back pain, particularly when they've got known dodgy spines. And I couldn't detect any abnormal neurology, but he was in so much pain. He was not really able or willing to lift this leg in the air, now push this leg down again, now bend the knee, now push against my hand. It was all a bit too much for him pain-wise. He'd been examined head to toe by the admitting doctor and then seen on the post-take ward round, and they'd examined his neurology, so that was reassuring.
Okay. So what are you challenging here? Are you thinking maybe this patient shouldn't have been admitted to hospital at all? Would you have sent him home at the front door?
I doubt I would have been able to. I always say to doctors who on post-it board and say, oh my gosh, I'm really sorry about this next one. I wanted to send them home, but I couldn't. And I will say, listen, I'm never going to give you a hard time for admitting a patient. If you thought that was the safest thing to do, please don't, you don't have to apologize for doing it. And sometimes you can't. And what are you going to do if you can't walk? Put him in a wheelchair, wheel him to the pavement and just say, bon voyage, and just leave him on the street. You can't do it. So sometimes you absolutely can't. So there we go. So I said to him, let's try again tomorrow.
Okay.
Stay in bed today. And I met him on the ward round the next day, and he was still in severe pain. He'd had some bloods done on this. This is day 3 now. His
Okay.
CRP was 104. It was normal
Ooh.
on admission. I thought that's interesting.
Okay, that is interesting.
Yeah. Why is it interesting to you? And I'll tell you why it was interesting to me.
So we've talked about CRP quite a lot. I think we like talking about the CRP, don't we? So CRP of 104 is pathological, I think. It's higher than, if it's like 40, 50, I'm like, yeah, 104, I'm thinking there's some level of inflammation going on in the body somewhere. Is this infective inflammation? Is this localized inflammation within the spine? Is it irritation? So I want to do a full set of bloods, actually. I'd want to look at his white cell count, his neutrophils. I want to look at his kidney function, his liver function. And I want to think about, okay, CRP, has this gone up because he's got a fracture? Check his ALK phos. Or has he got an infection? Has he got an infection elsewhere? Is it viral? Or does he have a spinal infection, such as a discitis?
Mm.
Or does he have a DVT? He's been immobile for quite a long time that can push your CRP up sometimes. Does he have a pneumonia? Although he's only been in hospital for 24, 48 hours, so unlikely to be a hospital-acquired pneumonia. So it wouldn't concern me too much, but because he was still in bed, he was still unwell, and he said this is the worst pain he's had, I need to know that there's nothing in that spine that's causing this CRP.
I remember learning in medical school, back pain and high CRP equals discitis until proven otherwise.
Yeah.
That doesn't really bear out in real life, I have to say. But you do have to think about it, absolutely. So I went to the patient again and I played hunt the infection. And the first thing I did was palpate his spine. Because when you have discitis, you cannot bear anyone touching your spine, right? It's really, really tender.
Absolutely.
And also I wanted to have a look at his back. I like to look at the painful bits in a patient. We've talked before about missing zoster, herpes zoster. A nasty attack of shingles can cause terrific pain. And if you don't actually visualize the skin, you can miss it. So I went to his bedside, I said, roll over, had a look at his back. No shingles there that could explain this horrible back pain. And his back was tender, but not desperately so. And I pressed up and down his spine with my thumb, and then I went on the paraspinal muscles as well, and it was tender, but he wasn't screaming in pain, but it hurt. I asked him about urinary symptoms, I asked him about chest symptoms, and I had a look at his skin, and I found the cause really. He had a patch of cellulitis on his left leg spreading up from the foot, which I wasn't entirely sure had been there yesterday because it was hiding under his compression stocking. But there you go. He had a patch of cellulitis. And I said, okay, this explains. And I said to him, actually, this might partially explain why you're in so much, why you had a really bad flare up. We know that chronic pain can flare up during intercurrent infections. So I thought if you're having a systemic response to a skin infection, maybe that's why your pain's a bit higher than it usually is. But a bit of flucloxacillin, and let's keep an eye on this. And I started him on fluclox. And I drew around the cellulitis. And I went on with my ward round.
This feels, it's like when you say to me, it doesn't feel, there's something missing. Or is that just my bias because we're talking about it on the podcast?
That's exactly what I was going to say. Do you think we think that though, because we brought this case to the podcast? So like,
probably.
What's the
going on
here? Yeah.
But I think it's, it feels incomplete, I guess, for me. I mean, the fact that you said that he rolled over is a good sign because obviously he was able to mobilize his spine. Discitis, I've seen a fair few cases of discitis actually. And I'm sure we'll talk about some of those actually in some upcoming episodes. But they're certainly in a huge amount of pain, and they've all had spinal tenderness. When you tap down the back of the spine, that spinal tenderness has been there. What was his white cell count and neutrophil count like?
Normal.
Okay.
And the rest of his blood tests were normal also.
Okay, so with discitis, it tends to be a lot higher because they're often very unwell as well, particularly if it's associated with TB of the spine, can be quite problematic. Okay. Why did he have cellulitis? He's 49 years old.
That's a good question, actually. We often stop when we think cellulitis, but you should look for the skin breach, shouldn't you?
Yeah. Was he diabetic? Did he
He
have
was not
athlete's
diabetic.
foot?
Do you know, he didn't have athlete's foot. So you're right. You need to look for the insect bite or the scrape or the cut or the athlete's foot, don't you?
Looking
To work
between the
out. Yeah.
toes. Yeah.
Yeah. Good
Exactly.
thought. Mm.
Hmm.
I moved on, and it wasn't until the afternoon where his bedside nurse came to me and said, "There's something wrong with this man." I met him the day he came in, and he was not this bad. He won't even allow the bed to be raised up so he can eat his lunch. He's lying completely flat and like log rolling himself from side to side. He was never like this before. So she said, and she hadn't worked for 2 days. She said she saw him on day one, and then she saw him now. She was really shocked by how bad his pain was. Um, So I delegated. I said to the SHO who was looking after that particular bed, I said, just go back and have another look at him. I know we've looked at him 20 times. Just go back and have another look because the nurse is worried. And they went away for about half an hour and they came back and they said, I've just done a neuro exam of his lower limb. He's got complete sensory loss from L3 down on his left leg.
Oh.
And I said, since when? Because he had a good neuro exam on admission and a post-take board round. My neuro exam yesterday was rubbish because he's in so much pain, and it was a cursory motor-based one. Can you do this? Can you lift this? Can you move this? Are your reflex intact? I didn't do pinprick. I didn't check his sensation going up the leg. So at that point, I was like, do you know what? We need the MRI spine.
Absolutely. Yeah.
Now something has changed, and we got an MRI spine that day. And this is a great report. Well, no, it's not great for the patient, unfortunately. Multi-level discitis with vertebral osteomyelitis and query impending canal stenosis at the lumbar spine. Recommend discussion with neurosurgeons.
Gosh.
Spoke to neurosurgeons, doesn't need surgery, conservative treatment, spoke to ID, who took over his care, already on the right antibiotics, flu clocks. They escalated it to 2 grams QDS and they admit him to their ward. And there's a lot to think about there, isn't there? Because
there's a lot to think about.
What should I or could I have done differently in this patient? If we were going to join all the dots of this timeline, I mean, the patient said to me, I'd like an MRI, please. And I explained why not. But where had I gone wrong? Cognitively speaking, I think the first thing that shocked me was someone who had recurrent flares of chronic degenerative spinal pain, came in with a absolute pattern fitting their acute flare, but this time had a rare condition associated with it. I guess that's Hickam.
Yeah.
He can have as many diseases as he pleases. But it was a zebra rather than a horse.
It was a zebra. Yeah.
And that
or
was
a donkey.
The first thing. It was something else that made hoof sounds. He didn't have that CRP of 400 and this screamingly tender spine, which I associate with discitis. That fits with my illness script for discitis.
Yeah, absolutely. Yeah.
So that sort of maybe drew me off on a different path. I think looking back, the cellulitis became a satisficing diagnosis.
Yeah.
Now, if you're going to challenge me on the word satisficing not being a word, go back and listen to our episode with Pat Cross-Kerry, who taught us about search satisficing in human factors and cognitive bias, and how you can, when you find a diagnosis which explains things away, you can stop thinking. A bit of premature closure as well. So there's quite a few things to unpick there for me. One thing I'm relieved about is that I hadn't caused this patient long-term harm. If they'd said transfer urgently for immediate decompressive neurosurgery, I would have been horrified because I would have thought I should have done this yesterday. And the fact that the treatment plan was sort of more or less unchanged moving forward, brought my blood pressure down a little bit. But it's not good. It's not a good feeling when this sort of thing happens. At least I found it and I did make the diagnosis. Could I have done it 24 hours earlier? It's what nags at you, isn't it?
Absolutely. Can I ask a maybe slightly challenging question?
Oh, go on then. It's a safe space. Go on.
Do you think you had any visceral bias towards this patient because of his chronic back pain?
I think in the way you mean bias, probably yes. I think there's the lay term of bias, which is an extremely negative term, and people think about stereotyping, bias, prejudices. And I honestly don't believe I have a prejudice against people with chronic pain, but maybe I do have a bias in how my brain works, my cognitive reasoning, in that I can attribute things towards a chronic illness, which might actually be a new acute illness. I think that's a fair reflection.
Yeah. I don't think you did anything wrong, Ben, because we see so many patients with back pain or chronic pain in AMU. We see so many patients that we also have to think about the pre-test probability. So what was this pre-test probability of this gentleman having discitis? 49-year-old man, immunosufficient, I can't think of the other opposite word for immunosuppressed. Immunocompetent, immunosufficient, what I'm meant about. Immunocompetent, had no history of discitis, was well in himself. And so actually his pre-test probability of this gentleman having discitis was low.
I agree.
And then something changed. And that's the key thing I think that as physicians we need to do is if something's changed, and that's when we need to re-question. And when it changed, the pre-test probability went up, didn't it? Because his CRP was high, he had pain, more pain, he had change in sensation. The pre-test probability of this being discitis was higher, hence MRI.
I don't beat myself up too much because I've got my view is I saw 150 patients that week, and this is the one. The one, and I am absolutely not perfect, and I'm not all-knowing. I'm a human being who's doing his best with the training that I've received.
Exactly.
And so I don't give myself a hard time, but I do like to try and learn and reflect and think. Ben, what could you have done differently there, mate? You might post to be, but I don't want to get to the state where I'm over analyzing and over imaging and over investigating. Everyone, because what's next? If we come in with a flare of their cyclical vomiting syndrome, and I'm ordering inpatient OGDs to rule out obstruction. I don't want to get to that space. We want to keep a healthy sort of overview of it. But I guess it certainly made me a bit more wary about discitis now. Maybe that old adage from the school, the high CRP and back pain is discitis proven otherwise. While not wholly true, maybe I shouldn't have thrown it out of the window in its entirety to kick off with. Why did I do that? Probably because I rarely see discitis, and I see a lot of back pains, and I see a lot of degenerative spines and radiculopathies, and it's painful and it's common.
Exactly.
And I felt safe to close prematurely, but to close at that point.
And as we said, common things are common and rare things are rare, and we can't think everything's rare. We can't diagnose everybody with a rare condition, can we? Because we don't have the resources, the space, and actually sometimes we'll be putting people through unnecessary investigations and tests and treatment when they don't need it.
Yeah.
I think that's one of the hardest parts of medicine for me is thinking about what investigations people need. Why do they need them? What happens if we don't do them? What's the pre-test probability? And I think that's where I spend a lot of time on that investigation.
What does the patient want, or what does the patient think they need?
Exactly. And that's a really important question. Yeah. And I think that brings into the final, when we think about clinical reasoning, shared decision-making is a big portion of that. And often we talk a lot about how we've made these decisions and we've thought about it. What does the patient want? The patient wanted an MRI. And I'm not saying was the right thing or not, but it's the same with cases that I've seen. The patient didn't want the DOAC. What do? Do you not give them the DOAC? And it's how we then manage. We've got the diagnosis, and then how do we manage the management of it, with that shared decision-making framework in mind?
And of course, sort of medical legally speaking, patients can, if they're of sound mind, they can decline
Of course.
any intervention if they like,
Yeah.
but they can't request one. They can't demand one if a doctor doesn't think it's right. So in that sort of way, we hold a lot of power with the patient-doctor dynamic. We hold the keys to the kingdom. And that's why some patients think they have to come in and beg or maybe beef up their symptoms a bit because they think this is what I need. How do I convince this person to let me have it? And I think as a human being, sometimes doctors, we know when that's happening, and it can sometimes put us a bit on the back foot, or even sometimes put us on the defensive a little bit, and make us sort of double down and say, I've said no. I'm not going to change my mind, and I'm sorry we haven't agreed on this. I'm sure we've done a podcast episode on this before where we haven't quite come to a happy consultation that we would have liked. And I think, and I don't want people to come away from this thinking the patient always knows, always give the patient what they want. That's not the moral of this story, I think. I think the patients have some really good ideas, and we have a duty to listen to them and then explain what we think what needs to happen and what we're going to do next. But it should be a collaborative decision as best as you can make it.
Yeah, absolutely.
Yeah. Easier said than done.
That is not where I thought that was going.
Yeah. You called it. I mean, you said disguises from the word go. But there you go. But it's nice, I think, for people to hear two different thought processes on this in parallel. Well, thank you for playing along with me today, Amy. I hope you enjoyed that case. It was a bit different.
I did. It was really different, actually. I really enjoyed it. I think it uses a different part of my brain. When we talk about different things, and because we do think quite differently, it's good to vocalize how both of us have completely different thoughts. We usually end up with the same endpoint. Yeah. We just get to it a very different route. Yeah, I go around the roundabout 72 times and you're down the M6. It's fine. We get there.
I was going to say there are many different paths to the mountain, but exactly. Get to the mountain. But yes, your M6 analogies. Anyway, let's wrap it up there. Thank you everyone for listening. I hope you enjoyed playing along. Maybe you guessed it straight away and you're a better doctor than me, but that's all the fun of the game. And please do tell your friends about our podcast. We love to grow it. We're getting bigger and bigger and bigger. It's a very little podcast that we do sitting at our kitchen tables, but we love doing it and we love getting your feedback. So please do write in if you have an idea about a case or you want to tell us about how you reacted to a certain case. But until next time, it is a big thank you and a goodbye from me.
Thank you very much. Goodbye.